Yeah, good evening, and thank you, Dr. John and Eknath, for introductions and allowing me to speak here today. Today, I'm going to speak on the deadly outbreak that we experienced in the month of January 2011 at Ahmedabad, and that is about Crimean Congo hemorrhagic fever. Just let me give you some the brief epidemiology of this Crimean Congo. This Crimean Congo virus is endemic in Africa, Eastern Europe, Asia, and it has got a 30% fatality rate. So this infection is associated with a very high mortality rate. And there are several reports of nosocomial outbreak with very high mortality amongst the hospital staff. So this is an area of big concerns to us. The CCHE is endemic in our neighboring country, that is Pakistan, and there are multiple healthcare associated outbreaks have been reported since the detection of the first case in Pakistan in 1976, and the recent outbreak was before 6 months of our outbreak. And CCHF has not been reported previously from India. So this was our first outbreak. We know the transmission, how the CCHF is transmitted. The most common route of transmission would be bite of a tick, that is Hiloma tick. But the interesting part of this tick is that it has no preference to bite human beings. So that is a very fortunate thing, that Hiloma has no preference to bite human being, and usually this tick selects animals for bite and to survive. But accidentally, when the human comes in close contact with this Hiloma, the persons may contract CCHF if the tick is infected. This is another route of transmission, and this has been well described in Pakistan, that when you come in contact with the tissue or the blood of any recently slaughtered infected animals, like what Pakistan journal described, that during the festival of Eid, there is lots of migrations of animals from the rural area to the Karachi, Lahore, Islamabad, the big cities, and they've been slaughtered. And this is one of the route of transmission, or one of the reasons for the outbreak in the cities of the Pakistan. So slaughtering the infected animals is one of the another important route of transmission, and this route of transmission is very important to us. So whenever we come into the contact with the blood of the viremic patients, especially when patient is having the hemorrhagic tendency, all the hospital staff, including doctors, staff nurse, and the other persons like those who are involved in the care of that patients will get CCHF infection. The brief clinical features of this virus: there will be a brief small incubation period of 3 to 5 days after tick bite, but this incubation period would be little longer when somebody is acquiring infections after exposures to the infected blood, that is 5 to 7 days. The persons can have a pre-hemorrhagic phase, which is exactly similar to any other viral infections. So there will be a sudden onset of fever, which could be very high grade fever. Patient will be having severe headache. Patient will be also describing chills and rigors. So the patient that we have admitted to a unit will be is having a significant rigors. Apart from these symptoms, patient will also describe severe myalgia. In fact, it is because of rhabdomyolysis. Patient will be having low back pain, abdominal pain, and photophobia. So if you look at this, the clinical presentations of CCHF, it mimics like any other viral infection, especially in the dengue and endemic regions like India. So most of the patients with dengue can have all these features. So from clinical presentations, it is extremely difficult to differentiate that patient could have the CCHF. But the hemorrhagic phase probably will differentiate from dengue fever. Like hemorrhagic phase usually develops very early when somebody is having CCHF, and usually after 3 to 5 days of onset of symptoms, patient will end up with profound and profuse hemorrhagic manifestations from the mucocutaneous area, where in dengue fever probably you are not going to get a severe hemorrhagic manifestation unless patient defervescence. Right? So usually after 5 to 7 days of symptomatology or the manifestations, the dengue patients, untreated dengue patients, can have complications, especially dengue shock and dengue hemorrhagic fever. So this is one of the very important features by which you can clinically suspect early hemorrhagic manifestation could be a clinical clue to CCHF. And non-fatal case, the patients recover, but this recovery would be complete, but patients can have prolonged fatigue and weakness even after years of recovery from CCHF. So let me take you to very important laboratory features of CCHF along with clinical correlation. So even in incubation period, there will be a brief viremia, but during incubation period, patient will start showing decline in the platelet counts, decline in the white blood cells counts, and there will be elevations in the liver enzymes. So even before there is a clinical manifestations, patient will start showing features of viral infection and early and rapid decline in the platelet count. This is a feature of CCHF. Usually we do not see a rapid and early decline of the platelet count in dengue fever. But with the onset of symptoms, there will be more marked decrease in the platelets, WBC count, and there will be elevations of liver enzymes. And the patient will enter into the hemorrhagic phase where patient will be having all the features of mucocutaneous bleeding, torrential bleeding, which is extremely difficult to control, and the features is like disseminated intravascular coagulations. And most of these patients, they die because of the hemorrhagic shock, secondary renal failure, or rhabdomyolysis, myoglobinuria, and the renal failure. So let me take you to the case that we have admitted at our hospital. This patient is a husband of index case. So we'll describe what is index case is. But let me take you to the case first. This gentleman was 32 years male. He is non-smoker, non-alcoholic patient, weighing 83 kilogram, and he was admitted with fever with rigors, true rigors, so it looks like some malaria, body pain, arthralgia, and occasional vomiting since last 3 to 4 days. So this was his brief clinical history. His vital data and physical examination was normal, except there was icterus and mild epigastric tenderness. He has no significant past history of medical or surgical illness, and he chose tobacco. So with this presentation, he came to our clinic, and his relevant past history, his wife died of undiagnosed viral hemorrhagic fever before 9 days of his onset of symptoms. The attending doctors of his wife died with hemorrhagic fever before 1 day of his hospitalization. The attending nursing staff was admitted with the viral hemorrhagic fever in critical stage into the same hospital. With all these 3 patients, they have similar clinical syndrome with elevated total CPK, elevated liver enzymes, acute kidney injury, and abnormal coagulation profile, including prothrombin time and APTT, and cytopenia and clinical hemorrhage. So with this relevant past history, this patient was brought to our hospital. So the patient was admitted in the isolation ward suspecting some unusual disease because attending doctors died, the wife died with hemorrhagic fever, and the nursing staff was admitted in critical situation. And patient was started with hydration, oral and intravenous, because I knew the history that patient will be having rhabdomyolysis and renal failure. So we started hydrating him, and we have started one empiric antibiotic, that is ceftriaxone. Carnitor is non-specific stuff that we also started just to take care of muscle breakdown. And oral sodium bicarbonate tablets given in view of maintaining urinary pH alkaline and supplementing vitamin B complex and vitamin E. This patient we have started loading dose of Ribavirin, that is 2 gram followed by 1.2 gram 6 hourly for first 4 days, and 600 milligrams 6 hourly to complete 10 days of total treatment. The actual dose, recommended dose, is 30 milligram per kg loading dose, followed by 15 milligram per kg 6 hourly for first 4 days, and 7.5 milligram per kg 6 hourly for next 6 days to complete 10 days. So we have given loading dose on the admission only to this patient, and we have sent his blood for viral PCR at our National Institute of Virology, Pune. And these are his laboratory parameters. On day of admission, his hemoglobin was 14.8, WBC count was 2600, platelets were 47,000, APTT was altered, and the prothrombin time was also altered with INR of 1.7. Creatinine was elevated, 1.2 is our upper level of normal. SGPT and SGOT were elevated. Bilirubin was 3.38, and CPK was upper level of normal, 280 was normal in our lab. LDH was 3 times elevated from the baseline. On day 1, he has hemoconcentration with further leukopenia, further drop in the platelet counts, and the prothrombin time gets little stabilized with improvement in the INR, but APTT remains elevated. Creatinine has started improving because of the hydration therapy, and liver enzymes remains stable. We have not repeated other investigations. On day 2, like he has started showing some recovery in the WBC but remains stable. The platelets continue to decline. There is further prolongations in the APTT, and prothrombin comes to normal, and the bilirubin that we did repeated remains stable, and CPK started elevation. On day 3, there is some improvement, and there is you can see that there is no hemolysis even though he is receiving massive dose of ribavirin. He has tolerated these drugs very nicely, and actually we were expecting more hematological toxicities associated with the very high dose that we are offering to these patients with ribavirin. So eventually, like on day 6 onwards, you can see that there is improvement in the hematological parameters, and we have discharged these patients on day 10, and he has tolerated these drugs nicely. The additional laboratory tests, like his C-reactive protein was 2.63, less than 1 is normal at our lab. Procalcitonin was less than 0.5, which was normal, so there is no bacterial activity ongoing. The tests for dengue, malaria, leptospirosis were negative, and blood sample that we sent to NIV Pune came positive for CCHF PCR, and after 2 days. And the nursing staff which was admitted to other hospital in critical condition, her blood sample also came positive for CCHF. So this is the outbreak that we had of CCHF. I think there is some disturbance in the dates here, but the case 1 was admitted on 31st December 2010, and she died after 5 or 7 days because there is change in the slides. So she has a brief hospitalization with hemorrhagic manifestations since she died. After the death of this patient 2 days back, this is a doctor. We could not test this doctor for CCHF because he already died before we admit these patients. So this is a doctor that we have admitted at another hospital, and he was admitted from 7th January to 13th January, and he died on the 13th January. The nursing staff was also admitted a few days after the hospitalization of the doctor, and she died 2 days prior to discharge of this patient. And this patient we have admitted on 14th January, and he survived, and we have discharged these patients. So out of these 4 cases, 3 patients probably we can say confirmed because C is an index case. This doctor is suspected case, nursing staff and this husband of the patient came positive for CCHF. So how do we treat this patient who presented to us with some unusual hemorrhagic viral fever? So whenever we are having some unusual hemorrhagic fever, we need to isolate these patients because it is extremely important that we have to prevent transmission of this viral hemorrhagic fever to our nursing staff and the treating doctors. So we have to look at the clinical symptoms. We have to take a detailed history whether they comes in contact with like the wife of our patient. They are working in a village and they are farmers and they are also raising cattle. So probably that is a source. And we did a surveillance in their village, and we found that few of the hyaloma ticks were positive for CCHF, and the serum samples that we collected from the animals, they were also positive for CCHF. So probably the virus was there in the town only, and this was accidental transmission to the human, and from that human being there is a human to human transmission leading to a small outbreak. So whenever you're looking at these abnormal clinical and the laboratory features, we need to isolate these patients and use all the barrier precautions to prevent accidental transmission. We need to send blood to confirm the common infections as well as the uncommon viral infections like CCHF, and we need to give ribavirin plus adequate hydration and supportive measures to reduce the complications secondary to rhabdomyolysis and the renal failure. The most important thing for the patient who recovered from CCHF is that no follow-up is required because there is no relapse. Once patient clears the virus, like it is a complete recovery, except the patients can have prolonged myalgia and fatigue, non-specific fatigue. So this is the dosage that we have already discussed about CCHF. So what about the use of ribavirin in CCHF? So we tried to search a literature and we found there is no clear message of benefit which is available from the current data on use of Ribavirin. Only the data which supports the use of Ribavirin are observational data. So we do not have clear-cut message, even though the Ribavirin could potentially have benefit from these conditions. And there are few studies, they have looked for in vivo and in vitro effect of Ribavirin on viral replication. So this is the in vivo the viral load measurement, and what they found that there is no difference in the patients who has received oral Ribavirin for the management of CCHF and those patients who has not received. And there is the same viral load even at the end of 10 days of Ribavirin treatment, and there is no the difference in the disease progressions. But even though there are few studies which supports and all these studies are observational studies which supports the use of Ribavirin clinic for use in CCHF. So after this first outbreak of 4 patients, we diagnosed 2 more cases of CCHF in Gujarat. Another MBBS doctor who is doing internship, and we interviewed him and his parents also. There is no contact with hemorrhagic fever patients, and he died within 2.5 days of brief hospitalization in February 2011. So exactly after 1 month of the first outbreak that we have reported, the intern doctors from Civil Hospital Vijay Medical College, he died with brief hemorrhagic fever. And the young female recently in the May 2011, she is again a cattle raiser, cattle caretaker from the village of North Gujarat. She came to our hospital and she died within 6 hours of hospitalizations from hemorrhagic fever, and she is also positive for CCHF. So out of 6 patients that we had with CCHF, 5 patients died and 1 survived. And out of 5 patients who died, 3 were medical staff and 2 were patients. Right? So when somebody acquires a disease from person to person, probably the case fatality rate is very high. So we need to be careful. This is what we were requested to publish immediately for CCHF in the month of February. And this is what we published in the September issue of Journal of Association of Physicians of India. So the important questions for physicians, like how to differentiate dengue and leptospirosis, which is again very common in our region, from CCHF clinically. So if you look at the dengue fever, there will be more bone pain and the back pain. Like, so this is how the dengue is described as a backbone fever. So there will be more back pain or the bone pain, while in CCHF there will be more myalgia because patient will be having rhabdomyolysis. So this is one clinical features. So you need to inquire in detail whether there is a bone pain or there is a myalgia. Leptospirosis will be again myalgia because again it will give you a rhabdomyolysis. The platelet declines to lowest when patient defervescence. This is the characteristics of dengue fever. So when patient is running very high grade fever, patient will still maintain a good platelet count, but when fever lysis occurs, the patient will achieve the lowest platelet in the dengue fever. But there will be early and the rapid decline in CCHF patients, or decline of platelets. The platelet is low platelet you will find in leptospirosis in up to 30% of the patients. So that is not a feature of leptospirosis. In lepto, there is a early renal and the liver involvement, because we know that in the leptospirosis, there will be large number of leptospira will be filtered by the glomeruli and will be blocking the tubules and produces renal insufficiency. And there will be additional liver damage in leptospirosis. In dengue fever, the prothrombin time is by and large normal. So you won't find abnormal prothrombin time in dengue patients, and only the APTT is markedly prolonged in dengue patients. Like in all 6 patients that we have treated so far, prothrombin time on day 1 is markedly prolonged along with APTT. So we make a rule that when the PT is abnormal, like make sure that you are dealing with something else which is nasty. PT may be prolonged in leptospirosis with normal APTT. This is a feature because it primarily involves liver and produces liver derangement, and which leads to the abnormal PT. So this is how you can differentiate. But important, the hematological differentiation between leptospira and viral disease would be there will be elevated WBC count in lepto, which is a rule, and you will find a neutrophilic leukocytosis, and there will be markedly elevated C-reactive protein. So this is how you can differentiate leptospirosis from this the viral diseases. Rhabdomyolysis is very well described with the dengue, but it is not that common. and rhabdomyolysis related renal insufficiency is also rare, while the rhabdomyolysis and the renal failure is very common in CCHFs. So this is how we can differentiate these three common the infections in our region. And we have to make sure that precautions are extremely important. So those patients who are admitted with undiagnosed hemorrhagic fever, we are not sure whether it is a dengue or it is something else. So we need to use a barrier precautions and isolate the patients. The severe hemorrhagic manifestations patients and patients with rhabdomyolysis and acute renal failure needs to be isolated, because Hunter syndrome can give you the similar features, and Hunter can give you leukocytosis. So this is how you should take care of this, and you have to notify this case to appropriate authority. And with this outbreak, the another important things that we have noticed, that more than 40 nursing staff has left the job from the hospital because of this deadly disease. So we were struggling with the nursing staff to keep on duty for management of these hemorrhagic fever patients. So nobody was ready to take care of these viral hemorrhagic fever patients.
They stayed away?
Sorry?
Have they come back, or they stayed away?
Yes, they have come back. But it was a very hard time to get a nursing staff, because the doctor died, nursing staff died, and again the doctor died. So Ahmedabad, Gujarat witnessed the first outbreak of CCHF. CCHF is new hemorrhagic fever in our clinical practice, and we should take barrier precautions while providing care to this undiagnosed hemorrhagic fever. The rapid drop in the platelets, elevated prothrombin time, sorry, along with APDT, and the early bleeding manifestations differentiate CCHF from DHF. Sorry. And CCHF is likely to be endemic because the surveillance says that it is there in the ticks as well as into the animals. So it requires further serosurveillance of the humans and the animals. Thank you very much for the patience listening. This is a young male patient with abdominal mass and eosinophilia. This is a real ID case, so don't look at this abdominal mass and eosinophilia. So this young gentleman is 25 years male, weighing 49 kilogram. He is residing in Madhya Pradesh. This is the central part of India. He is a student and he also goes to the farm. And he came to our clinic in May 2011 with a big mass, into the big palpable mass into the left side of the abdomen. And he described that this mass is since last 8 months. He started getting abdominal pain, anorexia and weakness since last 2 months only. So all these three complaints is since last 2 months. He has no fever in last 8 months, and he has no significant past medical history. And he was evaluated in his town by hemato-oncologist. The complete blood counts were within normal limit, except there is 10% of eosinophil. The liver profile, renal profile, LDH, uric acid, everything was normal. He was negative for HIV, HbSAg. Hematologist did his CT scan abdomen and took a biopsy performed from that big mass. And this lymph node biopsy was reported as a mucormycosis of lymph node, and this is a tertiary referral centers for histopathology. So this is most respected laboratory, from where it was a single line report that this is a mucormycosis of lymph node. There was no evidence of hematological malignancy, and he was referred for the treatment of mucormycosis of lymph node at Ahmedabad at our clinic. So the laboratory workup that we did at Ahmedabad was his hemoglobin was 12.6, count was normal, platelet was normal, but now there is 15% eosinophil, ESR was 95, C-reactive protein was elevated, normal level is 6 and it was 54, and rest of the biochemistry were within normal limit. We have repeated his abdominal CT scan because the previous CT scan was not in a good shape, and the CT scan showed a big inhomogeneous mass. You can see that occupying almost half of the abdomen. There were no obstructive features, there is no compressions over the bowel, there is no vomiting, patient was eating normally, passing stool normally, except there is a push of the bowel, and you can see the mesenteric vessels are traversing through the abdominal mass. And you can see some area of necrosis, and it is inhomogeneous, a big mass occupying half of the abdomen. So I was not convinced with the diagnosis of abdominal node mucormycosis because of the obvious reason that he is a young healthy male, no risk factors for mucormycosis, no past history of any major medical illness, he is immunocompetent, he is a student, and there is a long history of 8 months. Yeah, you cannot have mucormycosis ongoing for 8 months. Like, it is a very rapid angio-invasive fungal infections, and rapidly it will kill the patients, right? So I was not convinced with the diagnosis. So what is in your mind? These were my differential diagnosis, but what do you say about this patient?
Trying to think why would the pathologist confuse mucor with something else? I guess
Yeah, it was a single line report, mucormycosis of lymph node. That's it.
because a tumor would be the first thing, lymphoma would be the first thing.
Exactly. So low grade lymphoma would be a very common diagnosis. It's a big mass, and so we thought that probably, and that patient was evaluated by hemato-oncologist. So he would not have missed this patient because his LDH is normal, like twice. And TB cannot remain silent for 8 months. Like, patient should have fever. And TB will give you a periadenitis, so there will be lots of matting, lots of features of obstructions and bowel involvement. So TB is also unlikely here. Sorry?
No, it can all be very endowant.
Yeah.
How about leishmania?
Leishmania, yeah. But usually the visceral leishmania will give you more hepatosplenomegaly, the bulky liver and the bulky spleen. Here, if you go back to the CT scan, you can see the liver is absolutely normal. There is no hepatomegaly, and the spleen you can see it's not enlarged. The leishmania, visceral leishmaniasis will give you more the bulky liver and the bulky spleen.
It was confused with mucormycosis, so should probably think more about what kind of molds can cause something like this.
Okay.
Just saying something somebody else could. But I don't know what kind of mold can cause something so chronic. Competent
What else
patient.
would be like 90-degree branching?
Yeah.
So we also believe that pathologists will not make a major mistake like this. So we think for, other things, brucella, sarcoid, but not convincing differential diagnosis for this long history and this mass. So what we did a laparoscopic abdominal lymph node excision. So rather than taking a true cut, we excised a big mass of lymph node and sent for histopathology and the culture examination. And to our surprise, the lymph node grew mucor. So this is a mucor colony. You can see the lymph node tissue here, and surrounding that, the mucor grew.
VA could be a Golf has one.
25 years.
I don't know what Cindy Golf has a
Yeah, but she had leukemia.
Right, so we have started him on amphotericin B-deoxycholate. So we have started him on amphotericin B-deoxycholate 1 milligram per kg, and he was highly intolerant to amphotericin, which is again a surprise in my experience. Like, I have noticed that if patient has a disease, patient usually tolerate that toxic medications. Like HIV patients with cryptococcal meningitis, even though they are thin, lean, wasted, they will never end up with nephrotoxicity. They usually complete a full course of amphotericin. Even for antituberculous therapy also, when the patient is having mycobacterial infection, they by and large, even though they are having some bad liver, underlying chronic liver disease, chronic hep B, hep C, they by and large tolerate therapy. So we were just surprised that, like, we grew mucor and patient is intolerant to amphotericin B-deoxycholate. 2 days after, like, we got an histopathology from the lymph node, and this is a broad ribbon of mucormycosis. You can see there is a broad ribbon of mucormycosis into the lymph node. But along with this, there is the eosinophilic infiltrates eosinophilic abscesses, and there are multinucleated giant cells phagocytosing these zygospores. You can see these are the zygospores within the giant cells. So there is eosinophilic abscess, extensive eosinophilic infiltrations, and zygospores are engulfed by these giant cells. So we sent this isolate to our referral lab, that is at PGI Chandigarh, and this mucormycosis was reported as a Basidiobolus species, that is Entomophorale. So you are thinking in the right direction, that this is a slowly growing, less pathogenic mold which gives this infection. So the final identification is Basidiobolus species. So we stopped this amphotericin and changed to the oral itraconazole in little higher dosage, in divided dosage with the food. So the first follow-up was after 1.5 months, and he has clinical improvement. His pain disappeared, and there is regressions in the palpable lymph node. And after 120 days, just before my visit to USA, he came to my clinic for the follow-up. The lump was not clinically palpable. The patient was asymptomatic, but USG abdomen we repeated and still revealed small matted mass in these patients. So what is this? What is Basidiobolus? There is a very good systematic review in Journal of Medical Mycology of Basidiobolus infection this year, and these are all pediatric patients who has gastrointestinal Basidiobolomycosis, and the human disease is concentrated in tropical and the subtropical region. It is endemic in Uganda and certain areas of Africa, India, and other part of Asia, but is found worldwide. The organism spends part of its life cycle into the intestine of lizard, and it's liberated as a spores and the mycelia into the lizard excreta. The spores germinate and the organism grows saprophytically on the lizard's dropping, from which it may be picked up by the individuals with traumatic lesions or by ingestion. And this is how the person acquires these infections. This Basidiobolus species has a low virulence. Following experimental inoculation of Basidiobolus into the mice, invasive disease was not seen. So probably this is a less pathogenic mold. And it has been suggested that some of the unknown abnormality which may account for the disease, probably some intercurrent viral infections which leads to transient immune disturbances, and this might be a precipitating factors for some invasive disease with this Basidiobolus. And the clinical features of gastrointestinal Basidiobolus, like all reported patients, has fever. Our patient do not have fever, and abdominal pain as their main symptoms. Peripheral blood showed leukocytosis and marked eosinophilia as well as elevated ESR and CRP. So we do not have leukocytosis in our patients, but rest of the things were present. All pediatric the Basidiobolus patients were male patients with no significant medical history or apparent predisposing conditions. And the treatment, the Basidiobolus species has low MIC for fluconazole, itraconazole, ketoconazole, and miconazole, but has high MIC for amphotericin B, which can lead to treatment failure. Right? So take home message here would be like the culture and the species identification is very important for fine tuning of antifungal management for invasive infections, along with the histopathological examinations.